Good afternoon and a very warm welcome to this European Alliance for Transformative Therapies MEP Interest Group discussion on Mind the Gap, how to pave the way to access to authorized ATMPs for patients. My name is Jackie Davis. I'll have the privilege of moderating our discussions this afternoon, and we're going to have very interactive sessions, lots of opportunities to hear from our speakers, but also for you to raise any questions that you might have. If you do have a question, you can do it in one of two ways. Either please use the Q&A box to write your question, not the chat. Please keep the chat for any technical issues you might have. Use the Q&A box and please be as brief as possible so I can see at a glance what your question is and who it's for, or you can click on the raised hand button, and when the time comes, I'll ask you to unmute yourself, but not to switch on your camera. Let's limit the technological challenges we face this afternoon. The first part of this event is open, so if you want to tweet about what you're hearing, and we do encourage you to do so, please use the hashtag MEPs for ATMPs. For the workshop part, a little bit later on in an hour's time, we're going to do that under Chatham House rules, so hopefully people feel they can speak very frankly. And speakers, just to say, if your camera is not on, when I introduce you, please do put your cameras and your microphones on. We're going to get underway. As I say, we have a couple of opening speeches, short opening speeches to provide some context for our discussion, and then we're going to dive into our first panel. I'll tell you more about all of that later, but now I'm delighted to welcome Alessandra Moretti, who is a MEP, who is co-chair of the Transform Interest Group, to kick us off. Alessandra, thanks so much for being with us. Nice to see you, and over to you.
Thank you, Jackie, dear friends and colleagues. I would like to thank you for this event, and I'm very pleasure to address you today. I will be very brief with my introduction and hopefully open the discussion to a fruitful debate with some food and thoughts. The times we are living in today are complicated ones. So we have just been through a devastating pandemic, and now we see war being waged in Europe, a few kilometers outside of the EU borders. At the same time, our times show us also the many positive outcomes from the work of researchers and scientists operating all over the world with the only objective of elevating humankind and developing life-saving treatments for patients. In this context, the opportunities offered by innovative therapies are enormous. We might be on the brink of a change of paradigm in the treatment of many diseases, from long-term treatments to single-dose one-time treatments. It's our duty as politicians and decision makers to make sure that every patient has access to the best treatment available without any discrimination based on the country of residence or their social and economic conditions. In this sense, I share with many of you the concern regarding the evaluation of these new therapies. It's true that given the innovative profile of ATMPs, we should not use the same tools to evaluate their impact and benefits to patients as we are doing with more traditional medicines. We should be open-minded and ready to adapt the process of evaluation based also on other factors, such as their impact in the long term or the possible savings for healthcare systems coming from the one-time use of some of these therapies. At the same time, we should not be afraid of facing reality. The price of those innovative therapies is most of the times unbearable for public authorities. High prices keep innovative medicines out of reach for many patients across Europe, in particular in those poorer countries, resulting in growing inequalities in accessibility and standards of care. Costly new therapies often become available only for the lucky few or for no one in those countries that lack the purchasing power or are left out of marketing strategies. Sadly, the potential of these scientists and medical innovation remains underused, undercutting efforts to increase, personalize, and optimize treatment options for patients. I believe that everyone should do its part. Decision makers at EU and national level should promote a better environment for innovation and research, and also more flexible and up-to-date regulatory measures to allow those new therapies to be launched in our markets promptly when their added value with respect to existing therapies is proven. But on the other hand, we should also be ready to intervene and link the price of drugs of their actual cost of research and development, not to the need for patients for certain specific drugs. I strongly believe also that the current system of price negotiation at national level doesn't work in the interest of citizens and patients. The current system of negotiation is based on different models and methodologies rather than being coordinated at the EU level in an harmonized concerns matter. Negotiations with pharmaceutical companies are conducted by national governments and in most of the cases out of the public eyes instead of collectively and transparently. This fragmentation has negative consequences for overall price levels, accessibility for patients, value for taxpayers' money, and the sustainability of healthcare systems all across Europe. Also, I'm convinced that more conditionalities should be established, especially when public funding is involved in R&D, for example, in terms of fair prices, accessibility, marketism in all 27 member states. To conclude, I'm sure that with the commitment of everyone and the collaboration between public and private authorities, we will manage to produce a legislation for pharmaceuticals that will be modern and fit for the new era of treatment. Times ahead will be challenging. We will have many legislative measures from the Commission, so I count on your contribution to make the best out of them in the interest of patients. All the best for your discussion. Thank you very much.
Thank you very much indeed, Alessandra. And saying there, as you started by saying, it is our duty to make sure that patients, every patient has access to the best treatment available. You outlined some of the things you think we need to focus on in order to do that. I should mention at this stage that the Alliance, members of the Alliance have been working in recent months to define tangible policy asks in this area. And these asks, and you'll see a link in the chat to where we are with them so far, they reflect the Transform Alliance current thinking, and they will be kept under review and updated by the Alliance in the coming months to make sure that they continue to reflect changes in the external landscape and the political landscape and the policy landscape. And they will then be formalized and launched in a charter at a public event in mid-November. And as I say, they're already available on the Transform website as of now, and you will see the link appear in the chat. So thank you very much, Alessandra. I know you can't stay with us all afternoon, but we're very grateful to you and to the group for hosting and organizing this event. Thank you so much. I now want to give the floor to Dr. Alexander Natz, Secretary General of EUCOPE, the European Confederation of Pharmaceutical Entrepreneurs, for some opening thoughts. Over to you, Dr. Natz.
Thank you very much. Thank you very much for the introduction. Also, welcome and a big thank you to MEP Moretti, and welcome to all other MEPs in this session today. We are really at the right point in time to discuss ATMPs. When we look back 15 years ago, when the ATMP legislation has passed the European Parliament, we've come a long way. And only in the last 5 years, we've seen many ATMPs authorized by the European Commission. The European Medicines Agency has been very much involved. And only over the last 5 years, we are somewhat harvesting what we have been seeding 15 years ago. So that is a very important point I'd like to bring. We are now seeing those innovative products coming to European markets. Some of those companies with their ATMPs even come first to Europe, and that's really important for European patients, that we are competitive in that space with the most competitive territories around the world, which is the US. So in some instances, we have even been first. We've seen the CAR T cells launched in European markets. We have seen many other products launched in orphan indications. And I think it is really critical that we are taking note of the fact that at the regulatory level, I think we are really in a competitive space in the positive sense, so that there is no need really to turn things on their head to revise the ATMP legislation. We don't necessarily see a change there. However, given the fact that we see more of those innovative therapies coming in the pipeline, and the pipeline is quite rich and full in terms of our member companies, we have to take into account that we need to work with the payer systems and the HTA system to accommodate those therapies, to actually and ultimately also ensure access for European patients to those therapies. And as we have heard before, those products are different. Many of them are one-time therapies. So what we are used to reimburse in our national systems is chronic treatment options, where the costs are accumulating over the years. And now we are faced with a situation where we have a one-time cost up front, which tends to be higher than the chronic accumulated costs, and that sometimes overburdens healthcare systems. So there are solutions on the table. One of the solutions is clearly real-world evidence, and we are part of it in many initiatives in Europe, together with patient organizations, with the stakeholders, with the Commission, and also with EMA, to look at the value of real-world evidence. I think real-world evidence, which is the data which you're analyzing and after the product has been released to the market, can play a tremendous role to get the uncertainty out of the system, to make sure that payers are willing to reimburse those medicines. So I think there's a huge potential with the European health data space to make better use of real-world evidence also in ATMP. And the second element, which I haven't heard so much about in Brussels discussions, but which is frequently used when it comes to ATMPs at the national level, are innovative payment models. Outcome-based guarantees which the companies are given to payers, to national healthcare systems, to actually guarantee performance. And I think that is something which I would personally call very innovative, very positive, that someone commits to the performance of its own, of his or her own product. And I think that's really something which we should bring into the discussion also at the level of the European Parliament, because there are many new vehicles and tools developed in the area of cell and gene therapies, which we can also explore in other areas. Let me close with the fact that I would like to thank you all for bringing this initiative forward. It's a great pleasure to see that we have so many MEPs interested in this very important topic, because the pipeline, as I said before, is very rich. There are products in the pipeline for unmet medical needs where we don't have any therapy alternatives for patients. And let me also mention that we will also see ATMPs, cell and gene therapies, launched in non-orphan indication where the patient population tends to be wider. So we should be well prepared really to make sure that patients get access to those medicines as quick as we can. The HTA regulation is maybe part of the solution, but we should make sure that the particularities are taken into consideration. Thank you very much, Jackie, and to the whole initiative as well for having me here, and I'm really looking forward to the discussion.
Thank you so much, Alessandra, and pointing there already to some of the key issues we need to discuss. If that duty to ensure that everyone has access to these innovative therapies is realised, you talked about the European health data space and real world evidence, we'll come back on that, and particularly want to talk about those innovative payment models. What should they look like? What can they look like? What can we learn from initiatives so far? Lots to talk about, and giving an example really there, when Alessandra Moretti said at the beginning, we need to adapt the process to the specific characteristics of these therapies. You talked about that one-time upfront cost. Talk about how we adapt things to take account of that later on. But thank you so much, Alexander. We're very grateful. We had hoped at this point to have a speaker from the French EU presidency, but because of the presidential election and the official campaign, which began on Monday, representatives of the French government are now bound by a duty of restraint and therefore cannot speak publicly on French policy perspectives. So apologies for that, but we are delighted to welcome another member of the Transform MEP Interest Group, Radka Maxova MEP, for some opening thoughts, and then we will move to our first panel. Radka, great to have you with us. Over to you.
Thank you very much for the floor. Dear colleagues, dear esteemed experts, as a member of the Transform MEP Interest Group, I am pleased to participate in this discussion on access to authorized ATMPs. As my colleague MEP Moretti also said, given the ongoing legislative context, we have an opportune moment to address challenges that EU citizens face in accessing transformative therapies. European patients, especially those living with rare diseases, face serious challenges when seeking treatment. Those patients who do have approved treatment for their disease encounter barriers in delivery infrastructure, inequalities within and between member states, lack of information on treatment options, and the burden of upfront payments when seeking cross-border treatment options. In January this year, I co-authored a parliamentary question seeking the clarity on the Commission's intentions around the introduction of universal newborn screening in the revised OMP regulation, and whether it will develop an action plan for rare diseases, including EU guidelines and training for healthcare professionals. I am therefore delighted to see that the Transform Alliance policy asks to improve access to authorized ATMP include topics around early and newborn screening and genetic testing, and providing more training to healthcare workers on ATMPs. I believe we will be able to find and introduce new solutions for access in the upcoming revision of the OMP legislation, cross-border healthcare directive, and general pharmaceutical legislation. And I am ready to work with the Transform Alliance to help ensure these policy asks are reflected accordingly. I look forward to today's discussions and await the arrival of those promising legislative files in the Parliament, with my commitment to fight for the rights of patients to safe and timely access transformative therapies. Thank you for your cooperation, and thank you for your invitation.
Thank you very much to you, Radka, for your support for the work that the interest group does. We're very grateful to you, and raising some other issues there that we will come back to later on in our discussion. We're going to move now to our first panel. Just a reminder, during our interactive panels, if you want to ask a question, Q&A box, brief questions, please, or click on the raised hands button and I'll give you the floor when I can. Don't wait till the end to ask your questions. I will put them to our panel as and when I see them coming in, to the extent that time allows. So we're going to talk now and get some perspectives on realizing safe and timely patient access to authorized ATMPs in Europe. Joining me to discuss this, delighted to welcome Joe de Kock, Administrateur Général Honoraire at INAMI RISIV. Great to have you with us, Joe. Please do activate your camera so that we can see you. Simone Bosselli, Public Affairs Director at Eurordis, Rare Disease Europe. Very good to have you with us, Simone. Oswald Benting, Head of Market Access EMEA in the Novartis Gene Therapies Group. Hello, Oswald. Great to have you with us. And last but not least, delighted to welcome Billy Kelleher, MEP, another member of the Transform MEP Interest Group. It's great to have you with us and have your interest and commitment among all of you MEPs to this initiative. So, as I said, totally interactive debate. I have a few questions to get us started, and I'll be watching out for your questions or your raised hands. We want very much to focus on solutions here, because we've already heard about the challenges. But before we focus on what we need to do, I did want to get a sense from each of you just briefly on how you see the challenges, what for you are the most important challenges if we are to ensure that safe and timely access. Perhaps, Billy, I could come to you first, just as we've heard from a couple of members of the interest group already. Would you underline, when you look at the challenge to do this, would you underline the same sort of things that they have, or would you identify other things we need to focus on?
Well, I would very much underline and concur what was being said and what we must do, but I think the biggest challenge will be to get political will, particularly from Council, in other words, member states, to give up a certain amount of autonomy that they have around the issue of health policy. And that is going to be clearly a very significant issue. Like I would like to see, and I think the COVID pandemic did show European strengths and also its weaknesses, but in terms of this collaborative, cooperative approach in securing and procuring vaccines indicates that when Europe responds collectively, it can do great things. And of course, with transformative therapies now very much coming to the fore in terms of treatment and prevention, we do need to have a system in place that can allow the European Union to play a more central role, not only in the assessing and the approving and the assessing, but also I believe in the negotiations and the purchasing with the companies themselves, and then the reimbursement. Like the difficulty we have here, and I'll just give an Irish example. I mean, when Ireland had very tight budgetary constraints some years ago during a financial crisis, we effectively were funding medicines out of the central exchequer. So you were competing with keeping the lights on in a hospital with purchasing innovative drugs, and the lights in the hospital were always going to win. And that's just the harsh, unfortunate reality of the system as it's structured. So I'd like to see some form of hypothecated fund in Europe, a fund that would be just only for transformative therapies and for orphan drugs and medicines for rare diseases, so that there'd be a pipeline of approval. The EMA would approve, you'd have a health technology assessment, and then reimbursement. And that there wouldn't be this duplicity across member states, health technology assessments in Ireland, Portugal, Spain, right across, that there would be one centralized procurement and health technology assessment, and then a reimbursement scheme. Otherwise, countries that have tight budgetary constraints at any given time will not approve medicines. It's just as simple as that, and that's the unfortunate thing.
But you raised, of course, the important point. You started by talking about the political will. Question, is that ever likely to be something member states will sign up to? Maybe we'll get some thoughts on that later on. But Joe de Kock, from your perspective, the Transform Policy Hours highlight three key areas: healthcare system sustainability, assessing the value of ATMPs, and we've already heard a little bit about that, and this question of availability and cross-border access that we focused on a lot in a previous Transform meeting. For you, the most important challenges among those, what would you highlight?
I think these challenges are well identified. And of course, we can prioritize these challenges, but we have to take them all together. We know that medicines which are coming to the market will have a disruptive effect for our health systems. And the question is to be prepared how to handle this. And we know that these medicines are not the medicines of the past. These are the medicines of the future, of the 21st century. And we should adapt and align together, also in a European context, our processes to be prepared on that. And that's to do with a lot of elements. Of course, affordability and the pressure on our health systems, knowing that these medicines are coming to the market with high price tags, and we should understand this better. We should have, of course, appropriate answers to get the best evidence available as soon as possible, knowing, of course, that this is a long journey, and this what we need is clear evidence generation plans, which are based on good and good recommendations and evidence building. For the moment, we see that there is not a lot of coherence in all these frameworks, and I think the alignment in putting together with manufacturers, evaluators, buyers, because we are not payers, we are buyers. We should, as health insurers, ourselves are not as payers of pills, but as buyers of health for patients who are in need. And therefore, I think this disrupting medicines places or systems for these challenges which are identified. The question is not to identify challenges. The question is to be prepared and to find solutions for them.
Well, that's, as I say, what we want to focus on in a moment, Joe, but I just wanted to get your perspective on where the solutions are most needed before we delve into that. But you talked there about that alignment. And one of the issues I'd like to come back to is the importance of extending, and it's one of the things in the policy ask, the existing dialogues, early dialogues between everybody involved, and how important that could be. Let's continue to build our picture. Simone, in terms of where we need the solutions most, so what are the challenges where we have solutions and need them? What would you highlight?
Thank you, Jackie, and thank you for everyone. I must admit that having 3 different MEPs speaking in this language about the transformation of the European health system is refreshing. To be frankly honest, I was looking at the briefing and trying to respond. What is my most important issue now? Is it access to healthcare across borders for patients with rare diseases? Because effectively, the system that we have in place to access therapies that are authorized, that are available but not yet accessible for everyone that needs it in Europe is not there. However, with news from yesterday that one of the company that is producing some transformative gene therapies needs to strategically rethink his pipeline and his investment, thus potentially affecting existing therapies, tells me that we need to look at this in an ecosystem way. The access and availability doesn't mean anything if the environment for research and development is not appropriate in Europe. That will be the second time that for investment or lack of understanding between countries in assessing the value of a therapy leads to a withdrawal from the European market of not 1 but 2 potentially life-transforming therapy for rare disease patients. And that's what we really need to address if we want to be effectively ensuring that Europe is strategically positioned to be a leader in research and development, to be sustainable and autonomous, as is the stated objective is this commission and the current presidency. One last thing that I need to say about the French and the role of member states. At the EPSCO Council meeting on Tuesday, there has been an informal working lunch around rare diseases. And from what we hear and from what we read from the press conference and the follow-up, it looks like the member states are discussing concretely on how things should move on. And I think to what Mr. Kelleher said, relinquish some of that authorities that they have, in particular when it comes to rarity, is not an option, it's a necessity that is being recognized by member states.
Okay, thank you very much indeed. Let us continue to build our picture, and then we need to dive into those solutions and some very specific issues already being raised. Wim Gottisch, from your perspective, and you are, as I said earlier, from the Dutch National Healthcare Institute, ZIN, it's great to have you with us too. Wim, how do you see it? And when it comes to the focus, I mean, I was very struck there, Simone saying we're talking about, in these cases, therapies that are authorized, are available, but are not yet accessible. And he says the system is not there. We're going to talk at the next event organized by the Transform Group about regulation and approvals. But these ones that are already authorized and already available, what for you is the key thing holding us back?
Oh, thank you, Jackie. I think that it has been said already by some others, like Joe, that the sustainability of these therapies is crucial. And just to give you a quick example, we in the Netherlands produce a monitor of all our orphan drugs and relate the number of patients which are using those orphan drugs to the total costs. And just recently we saw that currently we actually nearly need 1 billion euros for approximately 20,000 patients. And if you translate that to bigger populations and seeing all these new therapies coming to the market, you can imagine that there are a lot of risk and a lot of thoughts for how we're going to pay, how we're going to fit this in the overall budget. So that is a crucial perspective from the age. On the other side, of course, we see all these new therapies, and we're quite aware that these, in some instances, provide solutions to patients which were not available yet. So what is this balance between sustainability and actually the added value to the healthcare system? And what can we do to actually guide, and I think it's also later in the program, to ensure that the ones which we think are really good come early to the patients with the right data, so we can actually ensure that there is timely access to these therapies in the countries. And I think the issue of early dialogues, which has been raised and will come up later, is, I think, crucial to guide this process.
Thank you very much indeed. And that balance you're talking about, I want to in a moment come to the very specific question, because we are at the moment when the HTA regulation is now at the implementation phase and looking at methodologies, for example, for joint clinical assessments. I'd like to get your thoughts on Alessandra's point about how we adapt that to the specific characteristics of these therapies. But let me come before we do that to Oswald Bentinck. And I wanted Oswald, I think Novartis, I think I'm right in saying, is one of the few companies in Europe that has successfully launched a gene therapy. Based on your experience, would you echo what our other speakers have said about the challenges that we face? Is there something else that you would highlight?
Yes, thank you very much, Jackie. Let me point out, we actually launched 2 gene therapies and 1 cell therapy successfully within Europe. I've been very closely working on one of those, which addresses SMA, spinal muscular atrophy. It's a one-time gene therapy. And yes, I do recognize what all the other panelists have said. I think the real challenge is around the perception of value and sustainability. I think there's a large kind of misunderstanding around how much these therapies cost. And granted, not all of them will present equal value, but there are some with a very high upfront cost. And without education, that's being misunderstood. People are translating that into, oh, wow, these are the most expensive therapies ever. But they're comparing it to the annual cost of treatment of conventional chronic therapies. And of course it's expensive, but these therapies can last potentially a lifetime, and they can be, in some cases might even be a curative. So I think the challenge is how do we avoid creating this almost perverse incentive where, companies start thinking, well, it seems to be easier and more rewarding to research and develop conventional chronic therapies rather than these one-time therapies. So there needs to be adequate reward to incentivize companies to look for these hugely innovative and, as others have said, transformative therapies. So the system, I think, definitely needs to evolve. I'm not saying that the system is incompatible entirely. As I said, we managed to launch these 3 therapies successfully, but I think for the future ATMPs that are coming, there needs to be that evolution where uncertainty is addressed through real-world evidence collection, performance, pay for performance type schemes or payment by results. But there has to be that acceptance of this long-term benefit, even with limited data, with the security, of course, that if it doesn't deliver, money gets paid back one way or another. And one last point, I think that, I don't know if we'll come onto it later, I think early access is another big problem for some of these highly transformative therapies, especially when it's life or death and no other treatments available. You see that you have regulatory approval, and then every country does its own clinical and economic assessment, and that can take time. And what we're seeing now is that patients, families are not necessarily willing to wait anymore.
Thank you. And let's dive straight in on that point. And Joe, I wanted to come back to you because I mentioned earlier HTA regulation, those methodologies for joint clinical assessments. And we are talking about, this is first in line ATMPs, first in line for the application of these sorts of assessments. And as Oswald was pointing to there, how do you assess it? How do you take account of the unique characteristics? You talked, and so did Oswald just then, about, as part of this, the importance of real world evidence. What do you think is going to be the key to making sure that the methodologies really work to address the challenges you've all been underlining?
Everything is coupled to everything. We have to bring together some elements. Start with early dialogues. We come later on, but these early dialogues are very necessary to see, okay, which data are we need to assess appropriately what the product will bring as value to the patients. We should, for the moment, we are confronted with an assessment at market launch. That is too late. We should do earlier on, knowing that a clear evidence generation plan is set up, but not only to take into account the market authorization or regulators' concerns, but also the payers and the patient concerns as early as possible. I think that's one thing we should try to achieve. And even we can say this early dialogues, why we should not have more pressure on that and prescribe this as something which could be mandatory in one way or another. That's one thing. Second thing is, of course, when this product is coming to the market, we know that there is not sufficient evidence. But when we have our evidence generation plan, of course, we agree that by ways of real-world evidence, for instance, and other assessment technologies, we can, of course, build on this evidence base and broaden this evidence base. Thirdly, of course, what we have to do then is see, okay, what is the reward at the moment that there is not sufficient certainty already on the basis. And that's one of the things. We know that this product will be costly, and I totally agree with Mr. Benting said. More awareness and clarity about the rationale of these high prices and these high price tags are needed. But what we have to do is, of course, putting together an access and this cost, but also how do we manage that when there is not sufficient evidence? How can we manage that? And I think in this way, progress should be made between manufacturers and payers. And of course, there is some reluctance with payers with regard to real-world evidence. Let's be clear on that. But let's not be naive. This is one of the tools we should use. It's not a standalone tool, but it's of course of great importance to see over the life cycle of the product what's going on.
Thank you. Wim, a thought from you on this and how to make these methodologies fit for purpose, fit for these therapies and their specific characteristics. And then I'd like to come back to Billy. And I'm wondering, we've already had a question from our audience saying, what are speakers' opinions on ongoing discussions about more coordination at EU level on rare diseases? What steps could the Commission take? So revision of the current framework and action plan. I mean, Billy Kelleher indicated for him, it's about political will. It's about recognizing the importance of doing things at EU level. How do you see the role of the EU within this, Wim? And do we need, for example, a common, we've talked about the health data space or touched on it. Do we need, would a common EU framework be helpful for this?
Well, certainly in terms of rare disease.
Oh, I'll come to Wim first just to get from the Institute, and then I'd like to come to you, Billy, to react to both of them. Thank you.
Thank you, Jackie. Apologies, Billy. What I would like to say is that what we struggle with is that the assessment, the joint assessments of clinical assessments of new therapies, which is foreseen in the EU HTA regulation, is based on a long process of actually deforming those methodologies. And I think one of the issues is that the therapies which we're looking at, ATMPs, for instance, quite often come to the market with a little bit different data set than traditionally pharmaceuticals have come to the market. And what you see, for instance, that we see those what we call single-arm trials, where we have data only in treated patients and subsequently comparisons made to patients which have had the same disease in history, historical controls. And I think that the challenge will be to really see how we can adapt the current template, which we have, to these type of therapies. And I think that is something I hope the UNETA and UNETA 21 will take forward, because I think that is really a really important thing. And regarding the data space, so the next step will be, for instance, if you want to have those historic information, which is real world data, then you need to have a system which is actually able to collect this data, but also to make those data available for all the stakeholders. And there are some elements which are currently under discussion in the European health data space, but are still, I think, far off from realization. I think our reality is that there are data in registries somewhere over Europe, but they are very diverse in quality. They're very difficult to reach. Subsequently, there are all kind of privacy discussions to which extent all the different stakeholders can use those. So over there's still some miles to make to really actually come to this concept where you have those real world data, for instance, to make this comparison to data which come from the single arm trials.
Thank you very much. And Billy, you wanted to come in, and this broad question, and you raised at the beginning, you said Europe the EU can and should play a more central role. And our questioner is asking, what do you think about in these discussions? Where do you think this conversation will go? We see a lot of will now to talk about a European health union. Is the real political commitment there to translate that into a reality in an area like this, do you think, the sort of things that Wim and Joe have been talking about?
I think it is in a limited phase, certainly from the point of view of rare diseases. I think that the political will is there. I think to go beyond rare diseases will be very difficult to get member states, because once you start giving up, your health to the European Union policies, well, then you're also giving up your budgetary independence as well. And that's the significant issue for the member states. But from my perspective, I would certainly like to see in the whole area of rare diseases, for example, newborn screening, developing the data from that, feeding that into the EU health data space, and then working with the innovators and the companies in terms of developing technologies and medicines and therapies for the profile of what is identified in the various populations across Europe. And that's really where I think the European Union can play a key role. And what we need to do is to ensure that, like people say there, from the point of view, Wim was making the point on the cost of some of these therapies is very expensive up front, yet they can have a transformative effect, and they could actually downstream have huge savings for health services. So we have to have that health technology assessment in place very quickly, and not when the medicine is approved by the European Medicines Agency, but in advance as well. I think, when you take the data from the clinical trials, etc., certainly there's a role to be played there, so that companies know then that if they spend a lot of money in terms of research and innovation, and they try to bring a particular therapy to market, that there is a reimbursement scheme that's in place immediately if it meets the criteria. And that is, otherwise we're going to end up with the innovation and the creativity done in other countries, and undermining Europe's autonomy in terms of its independence around supply of medicines and therapies, and that whole creative dynamic that we need to have for rare diseases. And really, rare diseases can be done at a national level, particularly when you have a lot of small countries like Ireland, Malta, Cyprus and others that simply don't have a population base, or maybe even the financial wherewithal to have enough facilities to deal with all rare diseases that may pop up in their populations. So there has to be pan-European in terms of data, but also in terms of assessment and reimbursement.
I want to move on to those innovative payment models in a moment, but I don't know, Simone and Oswald, do you want to react on this point?
I would very much like to, yes. Thank you. On the point of joint assessment, I think company position is very much that at a European level it's supported, provided, of course, that it leads to speedier access for these ATMPs, and that there are very clear rules and processes. I think there are two areas where there's a huge opportunity at European level. One is in terms of real world evidence, because right now what we face is a completely inconsistent set of rules and evidence requirements across countries. So it's very hard, especially in a rare disease, to track evidence in a way that suits every different payer. So I think there's an opportunity there at European level to set rules around how this evidence should be tracked, and potentially even to support the infrastructure needed to do so. And then last but not least, I think newborn screening was mentioned as well, and I think that's extremely important, especially in these genetic diseases where a lifetime of disability or even life saving, saving a life can be realized it's incredible to see the inconsistent application of newborn screening across Europe. In some countries, 5 diseases are screened for and another 40. So again, I think there's a huge opportunity at a European level to push for better application of newborn screening rules.
Thank you very much. Simone?
Thank you, Jackie, and thank you to everyone for highlighting so many different parts of this puzzle. I think if we start from the very beginning and just reminding, what does it mean to have a diagnosis of rare disease for a family or for a person, particularly when it comes primarily in childhood? It's a complete disruption of all the other areas of health, and but not only education, work, access to social services, etc., etc. And here we are only talking but to fulfill the potential of this transformative therapy, we need to start at the beginning. Newborn screening has been mentioned very often, but if we don't have from newborn screening the possibility to automatically go to the best available treatment across Europe, then what are we doing? Certainly it would help anyway, newborn screening. But one thing that we want to do, what I want to highlight, is that I have been in this position since 2017, almost 5 years. And I started talking about gene therapies and the access challenges at European level in 2017 when I joined, and we started a project called Rare Impact back then. Now we are looking now with a view of 2025 when the joint HTA should start with ATMPs. Now we are still looking at what methodologies are we using, which data should we collate. Now we can already build upon a very solid regulatory environment, a very solid project led by the EMA with the heads of medicine at the national level called Darwin, which already collate some of the data. We have the European reference network in place, which are dealing with it. Taking again the words from Mr. Kelleher.
Simone, we need to
last point.
Yep.
We have the regulatory assets. We got the assessment part. We need to build the negotiation part, which Mr. Kelleher already hinted on. We have a long history of pushing for this, and therefore we would welcome it. And certainly what the pandemic has taught us is that we can do collaboration at a member state level.
Thank you very much indeed, Simone. I'm sorry to rush you there, but I did want to come to this question of the payment models, those innovative payment models, and to what degree that they provide the solution to this question. Just to read out a comment from Mariam Krul from ESOP, and it refers to something Oswald said earlier, because she said the representative from Novartis was saying it's very important there is an incentive for companies to develop them, but with the number of trials running with ATMPs in my hospital, she says, it appears to me the incentive is currently huge, otherwise there wouldn't be so many in the pipeline. This means inevitably, she says, there is still room for tweaking the price down. It would be very beneficial if we could have a transparent discussion on true development costs and true profit margins with all stakeholders to see what we think is reasonable. Healthcare professionals who actually work with these products would be happy to participate. Interesting thought and idea there. Also, just coming back on this point of incentives, as it was you who raised it, and you raised the risk of a perversity of incentive, where it's better for you as businesses to go on focusing on chronic therapies, not these sort of one-time treatments. I mean, there is a general agreement that we need new and creative ways to look at this so that you can combine better access with rewarding and encouraging investment and innovation. What do you see as the key here? What do we need to do?
Yes, thanks, Jackie. Can I quickly respond to the point about...
Please do. It's part of the same equation.
Okay,
so
great.
Please pick up on that and your thoughts on where we can go from here.
Just to clarify, I mean, of course, I think every company is looking to develop the most innovative treatments possible, right? So, and yes, of course, there are many clinical trials going on, but you can see that many of those therapies, ATMPs, will not eventually be approved and become available. So, it's not fair to say that you need to be transparent around the cost, because ultimately, I think it's 9 out of 10 therapies in development never actually make it to market, so to speak. But coming back to your question, I think right now, I mean, what we've experienced so far, I'm happy to say, has been a goodwill on the side of the payers that we're negotiating with. I think everybody recognizes the transformative effect of these therapies and the innovation and wants to find a way to provide access. The problem is that the system is set up to assess the value of a chronic therapy. Chronic therapy, if it stops working after a few years, fine, you stop paying. You stop it. Whereas with the one-time therapy, obviously, you're talking about sunk cost. So there's a massive amount of uncertainty, especially for those that are potentially going to last, in terms of effect for a lifetime. So I think the system needs to evolve to allow for real risk share, and that can take any kind of shape. It can be pay for performance with rebates, but it can also be payment by results with a low upfront cost. And if certain outcomes are met, I mean, that's always the challenge again. It depends on the disease. Are there really clear outcomes that can be measured or can be expected? Then you can link payment to that. But there needs to be that sense that there's a long time horizon. Because you're front loading the costs into very few years. Payers have a very short kind of window that they're actually considering, and therein lies the challenge. So we need to be able to spread payments over time. We need to be able to link those payments to performance in order to ensure that there's a path forward for these therapies.
Wim, from your perspective, and apologies, I realized I missed your name out when I was introducing people at the beginning and didn't give your title properly. Special Advisor HTA at the Dutch National Healthcare Institute. For you, in terms of these innovative payment models and what we need to be looking at, and could there be, I mean, I keep coming back to this question because we're in an EU MEP interest group here. Is there a role for the EU, do you think, in terms of identifying some of the parameters for payment models that really work?
Well, I think that we feel from practice, and it's HCA practice and payer practice, that the ideas which are behind these kind of schemes are very promising, but the practice is very hard. Mm-hmm. And I think that is something we have seen, and we see a lot of discussion at all sides of the spectrum, stakeholders, industry, patients, HCA, to say, well, this is something we want to do. And subsequently, if you dig down to the practice, you see that actually very rarely these schemes work. Mm. And that we struggle with really the implementation of all the aspects which are essential for such a scheme, which, for instance, means that you have to agree on what are the outcomes which you are going to use if you're doing a pay for performance. Mm. Secondly, what kind of funding system is actually linked to that outcome? Is it a kind of spread payment, for instance, or is it really something which you would do at the end of the therapy at some moment? Do we have rebates, or do we actually say, well, we only pay every year an amount sum? And then I notice in my specific setting that also payers don't have actually the kind of systems, financial systems, to really organize this very efficiently. So I think I'm really supporting these kind of schemes, but we really have to learn from Europe. And I'm not quite sure whether Europe can dictate, but Europe can facilitate to make all these experiences more transparent.
Absolutely. And Joe, I wanted to come to you, and there's a question from our audience. What is the speaker's opinion on initiatives like Benelux, as well as the potential procurement of rare disease treatments? In broad terms, this mentioning here Benelux, there's also a Belgium, Ireland, Netherlands joint agreement, I think, on one specific therapy. Can you just talk about what we've learned from regional collaborations so far, and whether those sorts of regional collaborations, do you think, should be replicated?
I think they should be supported. That's the first thing. I think it's an experience which has already proven to be very interesting to continue. And one idea in Europe should be that, of course, all these networks can come together, not in one network, but learning from each other and exchanging good and best practices. With regard to Benelux, what we are doing is not common procurement, but prepare common negotiation and prepare common point of views with regard to do the evidence gathering, with regard to the understanding and awareness about the cost of these medicines and the way we can handle that. But with regard to the payments, of course, I think for the moment it's not as easy as possible with the European legislation to organize common procurement in this way. Of course, we have seen that in the vaccines, and we have seen that also in the world of the medications of COVID. But there's a different story, because here we are linked with medicines in which we should come to the real risk sharing, knowing that we need more evidence. But I'm a forerunner was a forerunner together with our colleagues to plead for more cooperation, knowing that smaller markets like Belgium and Luxembourg, Austria, Netherlands is a little bit bigger, but nevertheless we need to pool our resources, and it is linked to what Wim said. When one member state has to handle all these contracts and all this outcomes-based managed and entry agreements, I know it's our lovely words, but it's not so easy in practice to handle all this. Knowing what's coming up in the pipelines, we should try to find other measures and see, okay, what is indeed the value created over a lifetime? How can we organize that? And then we said we have other payment models needed, not to pay a high upfront cost and see we spread it in 20 years time without any possibility to correct linked to the evidence. I think there is a will to sit together with the manufacturers in a truly open dialogue. And as early we can start the discussions, the earlier the products will come to the market. No, we come too late, that's for sure. And this early dialogues also with not only on a scientific way, but also on the way of financing. What is the goal you want to achieve with regard to investment and return on investments and rewards? I think that's very important.
Thank you very much. Billy, a thought on this, if you would, generally in terms of how we develop these innovative payment models and how you see the role of the EU specifically within this. You're mute.
I see the European role as very important. I mean, like, there must be some form of a template so that, you know, people can benchmark off each other. I mean, if you look at the Zolginsa agreement between Ireland, Netherlands and Belgium, I mean, that is a very effective. They did a health technology assessment, joint reimbursement. So, I mean, that's the pooling of resources at a small level. I envisage that if we are really innovative in how we put forward this concept of a central European system that's not unwieldy, but it just uses the resources out there and brings them together, rather than we having 27 different templates across 27 member countries. Otherwise, we will be forever talking about rare diseases and patients falling through the various nets because of financial constraints of a member state or their inability to assess a gene therapy, for example.
Just to follow up on that, Billy, you raise an interesting point, because there may be people who say, fine, 3 countries collaborating together, that works, it can be agile, it can work, but make it a central European system and you slow the whole thing down. What would you say to those? You've said, no, it doesn't. What would you say to those who are concerned that might happen if we move to centralize it more?
Well, I mean, some countries are very good at doing the health technology assessment and others are very poor at it. And as I said, sometimes it's dependent on the financial wherewithal of an individual country at a specific time. And let's be under no illusions, countries do slow down health technology assessments and reimbursement when there are financial constraints. I mean, so what I'm saying is that if the European Union had a centralized role in it, I mean, they could assess it based on the fastest countries models. In other words, they would speed up the slow countries, but not slow down the fast countries. And I think if there was a hypothecated centralized fund then as well, it would give confidence to the innovators, it would give confidence to the companies to research, to bring products to market, knowing that there's a reimbursement scheme in place that can quickly start to reimbursement. Otherwise, companies may not stay in Europe, they may go elsewhere, or some countries will have the access to these technologies and other countries within the European Union won't. And that simply is wrong. when we talk about, European citizens having entitlements and rights across the European Union.
Thank you very much. Just want to read out a comment from Iona Psalti from the European Alliance for Vision Research and Ophthalmology on this, because she says Benelux as a model works for procurement, provided that the countries agree on HTA assessment. This cannot be upscaled until the HTA assessment is harmonized across member states. Simone, a thought on this before we move to wrap up this session and join. We'll move to the workshop. I hope most of you, if you have the time, will be able to stay with us for the workshop part, so we will hear from you again. But just on this issue of innovative payment models before we bring in our workshop speakers.
I think the innovative payment models that have been structured at country level are yes, innovative. Yes, they have been experimented, but they're also very complex for many reasons, complex to be implemented, particularly when it comes to gathering data. Clearly, we can upscale them, I believe, into a European setting. But more importantly, I would like to say to everyone, particularly also the industry and other manufacturers, that we need to look at this, what Mr. Kelleher was suggesting, as also as an incentive for introducing new therapies in Europe. If we have a more streamlined and secure approach from authorization to access, the companies, but not only the companies, but any sponsor, even from academia, will be feeling much more reassured that the therapies would be assessed in a much broader market, and concluding that, bringing that fragmentation that Mrs. Moretti was talking about at the beginning, the fragmentation of the European market. And therefore, I would invite everyone not to see a unified approach to procurement and to access as a threat, but certainly when it comes to rarity, innovation is essential, not only in products, but also in processes.
Thank you very much. We are going to move to bring in our workshop More Alliance members and hear some more from them about their experiences and their thoughts. And as I say, we can come back on these issues during that. But before we move on, you've all talked about the importance of early dialogue. I don't know whether anyone has a thought on how we can improve on what is already done, because it does exist. How do we extend it? How do we ensure that really works? But most crucially, and this is probably unfair, but I'm going to ask it anyway, for each of you, and I'll start with Simone this time and go backwards the way round I went in, as it were. Simone, if you had to identify just one concrete policy change that you would like to see as a result of the current review that is going on at EU level of the general pharmaceutical regulation, but also the medicines for children, rare diseases, on one thing above all else you want to see them change, what would it be? Same question to you all.
Oh, come on, Jackie. You want a silver bullet from me? I'm sorry, it's totally unfair. Well, one of the proposals that we have doesn't need to be even a change in the legislation. For example, we believe that developing an orphan drug development plan at the European Medicine Agency level, involving from the very definition of the first encounters between a sponsor and the regulators, involving the experts in the Committee of Medicinal Products, then establishing an early dialogue, early and not only early, but iterative dialogue that will bring a better development process, because the expert can then suggest what they think will be a better development plan that would actually, in hypothesis, reduce the current attrition rate, which for rare diseases is very high. It's in line with everyone else, but is even more important in rare diseases when you have less opportunities.
Thank you very much. And Simone, I do hope you can stay with us for the next part and we can come back on some of these issues. Oswald, the one thing you would like to see done.
Thank you. It's a tough one because I've got a few I'd like to highlight, but if I stick to one, I would really like to see kind of what I was alluding to before, a central role played by the European institutions, whether it's the Commission, I don't know, but to come up with a uniform set of rules around evidence generation, especially the real world evidence context, because I think, especially in the case of ATMPs, that would really ensure that the uncertainty would be addressed around these therapies, that you wouldn't have all these trust issues with different centers and different evidence requirements, etc. I think that would be a massive win for all ATMPs, and I think it would be the biggest driver of accelerating access and getting payers to accept the uncertainty, to understand that, it's less. I see not everybody agrees.
Thank you very much. Wim, from your perspective, the key thing we need to do above all else.
Well, I think in some line, I agree with Oswald that actually a better understanding on evidence generation, exactly about real world data. I think Joe knows because he's coordinating a very big effort in terms of real world evidence in Europe. But there are many initiatives going on in Europe, and actually the Commission is currently sponsoring another call for many new initiatives. And I have no feeling that there is any coordination in Europe regarding how we're going to do this. In that sense, I support Oswald's approach to move this forward, and I don't think it's acceptance of uncertainty, but it's more that we have a common vision on how we assess these data and how we're going to use those data.
Thank you very much. Joe?
Yes, when I was disagreeing with Oswald, it's not about the approach, of course. We are convinced that these products should come to the market when they have, of course, value for patients. I think one of the ideas we should think of is to see that the evidence generation plans, which are in the regulation, and you are talking about regulation, are implying sufficiently and leading also to commitment of payers in the same time, that it's not breaking the bank in the different member states. It's saying, okay, we payers or buyers of health and also regulators together with patients and other involved stakeholders involved, we agree on this evidence generation plan, and we will not restart all the discussions again. We should do this as early and on an iterative basis. That's for clear. But that will say, as Mr. Kelleher said, that at the moment these products are coming to the market, the questions are not solved, but there is a clear understanding on what's coming up. Then, of course, we should look to the way of new payment models. But you asked me one thing. That's one important thing we should reflect on. It's nevertheless a second thing. It's data, because this evidence generation must be implemented also. And of course, there is a great endeavor also for the European Commission to see, okay, the secondary use of data and so on. How can we manage that? And third, I think it's
very briefly, Joe.
Yeah, that's the last word. I think it's important also that there is sufficient support for the member states, because they will they have to implement it in practice, and there should be alignment between all these lines and these processes.
Thank you. And we can come back on these issues during the workshop. I hope, Joe, you'll be able to stay with us for that as well. But I wanted to give the last word in this session to Billy Kelleher. I think we've come full circle, Billy, to where we started, and with your plea at the beginning for more Europe here, very much being echoed, but people being quite specific about where they see Europe adding the value. What for you is the key thing you want to see happen now?
Well, there's two things I'd love to see, and I think they could be moved on quickly. A European-wide newborn and early screening programme and genetic testing. I'd like to see that uniform across the entire European Union. And then I'd like to see a more centralised health technology assessment system that can collate all the data from all member states, can access information from clinical trials, so there can be a seamless transition from approval to reimbursement for innovative therapies.
And Billy, just one other thought, if I could. I don't know whether I doubt you can stay with us for the next bit. I'm sure you're very busy, but I just wondered, going back to your political will question, if you had some advice for members of the Alliance who are not the MEPs, so trying to influence politicians to really make progress on this issue, what do you think the key is to generating, briefly if you would, that political will?
Well, I mean, first and foremost, it's the right thing to do. But secondly, I think it would actually take an awful lot of pressure off individual governments across member states, who very often play God in terms of approving medicines or not approving medicines because of financial constraints. So if that was passed to a European agency and European reimbursement, well, then it takes that decision-making process away from governments. And just finally, we've had situations outside the Irish Parliament over the years where patient advocacy groups, along with politicians, would be protesting in the rain, trying to get medicines for children with cystic fibrosis, you know, trying to put pressure on governments because of financial constraints. The government were saying no. So, I mean, that's just not a way to do business. The way to do business is to do it in such a way that there's a streamlined process, it is fair, it's honest, it's transparent, and every patient across the European Union will have access at the same time, as opposed to depending on who you are or where you live.
Yeah. And Billy, I don't know, do you have to leave us now?
I do, unfortunately, yeah. Jackie, I have to go, but I will have somebody else listening in on my behalf.
No, totally understand. One issue that's just come up in our Q&A, and just to explain about the improvement of cross-border healthcare, we did focus on this issue very much in our last event. So we've been focusing on these other aspects today, but during our workshop discussion, we can, of course, come back to that. I also have a comment about newborn screening, but again, we'll come back to that during the workshop. Billy, thank you very much. Those of you who can stay, it would be great if you did, and you can react to what we hear from our other Alliance members, but very grateful to you for now. Thank you very much. So we're now going to move to that workshop session on Transform's commitment to ensure safe and timely patient access to ATMPs in Europe. We're going to explore in more detail with some Alliance members how to support and improve that access, just to aligning on a Transform position in the context of that pharmaceutical strategy that we've been talking about. Delighted to hand over to Andrzej Knotek, who is co-chair of the Transform MEP Interest Group, for some reflections on what we've heard, Andrzej, and where we go from here.
Good afternoon, good evening, and thank you very much, Jackie, for the floor, and also for having moderated this debate. On behalf of the Transform MEP Interest Group, I would like to, from heart, thank to all participants for their fantastic interventions, and not only fantastic, but also timely. And when it comes to the word of timely, I would like to ensure that it's a priority of our MEP Interest Group to ensure timely, affordable, available, and also authorized ATMPs to our patients in EU. And thanks to today's debate, we have really been able to build on, and you have given us a lot to reflect on. Also, I would like to thank to the Transform Alliance, which has successfully helped to put together all of those policy asks, and thanks to them, we will be able to address the gaps and the needs in the upcoming legislation. If I can say one key takeaway, and I feel it from the debate, it is that the stakeholders are ready. Stakeholders are ready through EU-wide solutions to bridge the gaps that are among the patients on one side and the available treatment on the other side, either through this more coordination on the horizon scanning or more cooperation among the regulatory authorities, HTAs, and the payers. Of course, real-world data collection and processing through tuned up EU health data space. We cannot move forward without innovative payment models, and also often spelled was the cross-border access to the infrastructure and the treatment itself. So once again, many thanks for amazing 2-hour debate, and also for the future, because we are going on, we don't stop, we start. So it would be my pleasure to invite you on the June's event, also hosted by the Transform MEP Interest Group. It will take place on the 16th of June, and it will focus on EU regulatory framework for ATMPs. So this will be in June, and very important event in October, not a fixed date yet. However, more important, it will be a physical event, hopefully physical event in the premises of the European Parliament, and we will launch the official MEP charter outlining the key policy asks. And the timing in October is also well considered because at the same time the European Parliament will be reviewing some Commission's related proposals. So this would be fantastic to meet you all there. And last, allow me to invite you to a small homework, if I may, to call it like that. The Transform Alliance is active on the social media, so feel invited to visit the LinkedIn profile or the Twitter profile, share, chat, like, whatever as you feel. So once again, thank you very much to all of you for a fantastic afternoon. It was my pleasure to be with you. Thank you.
Thank you very much for hosting us this afternoon and for those great reflections on the end. And as Andre mentioned, though that the October event, that chance to meet in person after all these great online events, but it will be lovely to meet many of you, having had the privilege of chairing these meetings, will take place in mid-October with the launch of the Charter. In the meantime, you can see those policy asks on the website. They are under review, as I mentioned at the beginning. They are being updated in light of what happens in the political and policy landscape, but do take a look. And June 16th, as Andre said, join me and our speakers for the next online meeting where we're going to look at the regulatory framework. But thank you all very much indeed for a great and inspiring discussion. It only remains for me to wish you all a very pleasant evening. Thank you and goodbye.